This next section on coagulation disorders is on secondary hemostasis disorders, which are clotting factor deficiencies. Remember that the liver synthesizes clotting factors. So if there's liver disease, there'll be less clotting factors produced and increases the risk for bleeding. If the clotting factors are vitamin K dependent, the liver will still produce the factors, but they will be inactive. It's interesting to note that bile is necessary for vitamin K to be absorbed, so people with gallbladder disease may also be at risk for bleeding. Any kind of viral infection, such as HIV, CMV, etc., can produce immune complex mediated injuries to the platelets. Also antiplatelet antibodies and a decrease in megakaryocytes in the bone marrow. Remember that megakaryocytes are the precursors for our clotting factors. Hypersplenism is another problem. The spleen normally holds about a third of our platelets. In hypersplenism, it sequesters up to 90% of platelets, which of course, therefore, we don't have platelets to perform the platelet plug in the first part of the hemostasis. Treatment for that is splenectomy. Clotting factor deficiencies will be discussed in the next few slides. Hemophilia A is an X-linked recessive disorder and the most common type of clotting factor deficiency. Factor VIII is also known as anti-hemophiliac factor A and is needed to activate factor X in the intrinsic pathway. Note how factor VIII sounds like A, and it is anti-hemophiliac factor A. That may help you remember that factor VIII is associated with hemophilia A. Note that the bleeding time would be normal and the platelet count, but they will have a prolonged PTT. Because this affects factor VIII, then this affects the intrinsic pathway, as do all of the hemophilias that will be discussed. When symptomatic, hemophilia A is seen as hemorrhaging following trauma, especially in joints. It is diagnosed by the factor VIII assays that are done. And although there's bleeding following trauma, petechiae and ecchymosis is not present. Hemophilia A is treated with infusion of factor VIII. Factor VIII is derived from human plasma, so there's a risk of transmitting viral diseases when administering factor VIII. Cryoprecipitate, also a component of blood, is rich in factor VIII and fibrinogen and can be used to treat hemophilia A. Von Willebrand's disease is the most commonly transmitted genetic bleeding disorder. As an autosomal dominant trait, it affects 1 in 1,000 persons, both men and women. Von Willebrand's disease affects factor VIII. There are two separate factor VIII proteins, factor VIII VR for von Willebrand's disease and factor VIII. Von Willebrand's is produced in the cells that line the blood vessel walls and acts as a carrier for plasma factor VIII. It binds with collagen, heparin, and platelet membrane glycoproteins in hemostasis, and is mainly facilitates binding of platelets to collagen. Remember that factor VIII is needed to activate factor X in the intrinsic pathway. Von Willebrand's disease is diagnosed by ruling out other reasons for bleeding. Von Willebrand's is characterized by spontaneous bleeding from mucous membranes or from wounds, and in women, having uterine bleeding is the most common sign. There is no cure, but it is treatable. For women with heavy uterine bleeding, birth control pills are prescribed. Some antifibrinolytic agents such as Amicar, clotting factors, and if life-threatening, cryoprecipitate can be administered. People with von Willebrand's disease are taught to avoid high-risk activities so that they aren't put themselves at risk for injury that can cause bleeding. Hemophilia B, also known as Christmas disease, named after the first person identified with this disease, is a deficiency of factor IX. It is a X-linked recessive trait, and it is pretty much indistinguishable from hemophilia A, with a prolonged PT and normal bleeding times. That's different from the von Willebrand's disease, which has a prolonged bleeding time with normal platelets. As you can see, hemophilia B is relatively rare. Hemophilia C is a factor XI deficiency. It is an autosomal recessive trait and occurs equally in men and women. Bleeding is much less severe than in hemophilia A or hemophilia B. Generally, the severity of bleeding in hemophilias is dependent upon the amount of clotting factor concentrations present. If the concentrations are less than 1%, it's considered severe and spontaneous bleeding occurs. If the clotting factor concentrations are between 2 and 5% of normal, then it's considered moderate and bleeding only occurs after trauma. If the blood clotting factor concentration is between 6 and 30% of normal, the hemophilia is considered mild and bleeding occurs after severe trauma or surgery. Although clotting factors are not transmitted from mother to baby, bleeding in the first year of life is infrequent because the decreased risk of injury to the child, to the infant, except for in cases like circumcision when it's a planned type of surgery. Remember that hemophilias are an intrinsic factor disease, so that clotting from tissue trauma occurs with the extrinsic pathway, so that most clotting occurs naturally as not affected by the hemophilia and is not involved in factors 8, 11, or 9 as in hemophilias. We might see easy bruising and hematoma formation after injections or from firm pressure administered to the child. By the ages of 3 or 4, most hemophiliacs have had some episode of persistent bleeding. Bleeding occurs in the GI tract and then joints. Bleeding in the joints is very painful, can also lead to degenerative joint disease as these children age. This concludes this section on coagulation disorders. One more section to go.